How long should a successful nerve block last to confirm pudendal neuralgia? Do you recommend transvaginal versus transgluteal? I only got some relief from it done transvaginally. So positive pudendal nerve block is part of the NANT criteria. It is also a part of the criteria that I am trying to create, which I would like to call the Phoenix criteria. And hopefully one day I'll validate it. The reason to do the pudendal nerve block and the reason why we want the pain to disappear temporarily is because there are multiple nerves that innervate same part of the pelvis. So if we are trying to make a decision to operate on the pudendal nerve, we want to make sure that it is the pudendal nerve that is causing this pain. So just to give an example, the clitoris is innervated both by the pudendal nerve and it's innervated by the genital branch of the genitofemoral nerve. So if patient has an injury to the genitofemoral nerve, she may be experiencing the clitoral pain. And if you block the pudendal nerve, the patient may have numbness in the clitoral area, but she will still have the pain. And that's the reason why we want to do that block, because in such a patient we would not operate on the pudendal nerve. So when you do the pudendal nerve block, it doesn't matter how long it lasts, as long as the patient has numbness, and together with that numbness, the pain goes away for as long as the local anesthetic is working. So if someone has plain lidocaine, which works for an hour, then the pain will disappear for an hour, maybe a little bit shorter. If patient has lidocaine with epinephrine, it may be 2 hours. If the local anesthetic used on the block is Marcaine, it may be 5 hours. Marcaine with epinephrine may be 7 hours. So the length of how long the block works for really depends on the type of the anesthetic that is used. So what is more important, whether the patient actually had numbness and the relief of pain, not how long it lasted. The way that the nerve block is done, it really doesn't matter that much as long as the patient is actually numb. So whether it's done transvaginally or whether it's done with a CT scanner or the ultrasound or using a C-arm, which is the X-ray, as long as the patient has numbness after the block and the pain goes away with that numbness, that's a positive block. Some physicians are very good doing the blocks unguided and doing them vaginally, and some physicians do them with a CT scanner, and some physicians do them with a C-arm. And again, it doesn't matter as long as the block is done properly. But what is very important is to make sure that there is numbness after the block is done, because again, I mentioned that before, but there are so many patients that I see that come and tell me that they have had a pudendal nerve block which did not relieve their pain at all. And when I ask them, were you numb after that block? The patient says, no, I wasn't numb at all. And what that means is that the block was not done properly. Because if the pudendal nerve is truly blocked, meaning the anesthetic is injected right next to the nerve, then there should be numbness. Now, whether the pain will go away or not, that depends if the pudendal nerve is the nerve that is involved in patient's pain. The third part of the question that patient says, well, she only had some relief when it was done vaginally. And I see that sometimes when the blocks are done one way, it works, and done the other way, it doesn't. And usually I actually see that the blocks that are done transvaginally may have a higher success. I think it sometimes may be related to the scar tissue that is around the nerve, and sometimes when those blocks are done transgluteally with a CT scanner or with a C-arm, there may be a lot of scar tissue and the local anesthetic may just not be getting to the nerve. But when it's done vaginally, somehow you may be bypassing that scar tissue, and I think there is a higher likelihood in some patients that transvaginal blocks will work better or are more likely to work than blocks that are done using a CT scanner and transgluteal approach.